Everyone, if you're joining us early here, we're going to give it a couple minutes for all the registrants to get here live, and then we'll kick things off promptly. Thanks. All right, everybody, we're going to kick things off here. Welcome to our first episode of 2024, and thanks for joining us again on our 15th episode overall of Ewings U. I'm Pierre Espada, and once again, I'll be your host today. And I'm also co-founder at Little Warrior Foundation, and more importantly, father to 13-year-old little warrior Lucy. If you're part of our core contingency, aka the Little Warrior Fight Club, thanks for being here with us since day one and making this a place for positive change. And if you're new, welcome to Ewings U. It's our webinar series where we hear from leading sarcoma experts and discuss the cutting edge of care and the science behind Ewing sarcoma. And speaking of cutting, sorry for the terrible dad joke. I'm entitled to one a year. Today, we'll be hearing from one prominent expert in the field, an orthopedic oncologist, Dr. Sharschmidt. And all joking aside, I'm super grateful to have met you, Dr. Sharschmidt, and a quick shout out to Dr. Setti at Nationwide Children for connecting us both. Today, specifically, we'll be hearing with Dr. Scharschmidt. We'll be exploring multiple innovative surgical options, including the use of virtual surgical plans, 3D modeling and custom implants, and bioprosthetics that are now viable surgical options to explore for kids with Ewing sarcoma. And other than being innovative, the ultimate aim of using these modern technology is to improve patient outcomes. Briefly, a little bit about Dr. Scharschmidt. He received his medical degree from Northeastern Ohio University's College of Medicine, completed his residency at Summa Health System, and he then thereafter completed a fellowship in musculoskeletal oncology at the University of Washington and Seattle Children's Hospital. He also trained in advanced reconstruction and tumors of the spine at the Texas Back Institute. Currently, he's the director of pediatric orthopedic oncology program at Nationwide Children's Hospital and a professor in orthopedics at the Ohio State University Medical Center and James Cancer Hospital. On the research side, his interests include basic biology and the molecular mechanisms of sarcoma, advancing the care of amputee patients, prosthetic implant design and technique, and improving expandable implants and limb salvage for pediatric patients. He has published more than 100 articles and 8 book chapters. On the clinic side, his interests include bone and soft tissue sarcomas in adults and children, benign bone and soft tissue tumors in adults and children, complex limb reconstruction, and advanced reconstruction options in the growing child care for oncology, amputee patient, and spine tumors. He has received numerous awards, including Educator of the Year in Orthopedics and Medical Student Teacher of the Year. And he is consistently ranked in the top 1% of physicians in patient satisfaction. And last but not least, when Dr. Scharschmidt isn't working, he enjoys spending time with his wife and tending to their 6 kids' busy schedules in what he calls a semi-organized chaos. I truly appreciate that perspective there. And before we kick things off with Dr. Scharschmidt, I just want to let everyone know and remind you all that Ewings U is a production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a complete and permanent cure for Ewing sarcoma. We were founded in April 2020 and have now granted out $1.6 million in high potential therapies, more to come soon on that as well, for increasing survivorship and decreasing toxicity. And in order for us at Little Warrior to make programs like this a reality, we rely on the support of little and big warrior communities alike. We appreciate all of your support so that we can continue our mission of bulldozing our way towards more effective and less toxic therapies and continue this vital work for kids battling Ewing sarcoma. With that, I'm going to hand it off to my omnipresent co-founder and co-host, Emily, to introduce herself and touch on a couple of housekeeping items, and then we'll be on our merry way.
Omnipresent. I like that. I'm Emily McFadden. I'm one of the co-founders of Little Warrior Foundation. Just a couple of housekeeping items today. This session is recorded, like all of our episodes of Ewings U. If you want to rewatch this or catch some of our previous episodes, you can find those at littlewarrior.org underneath the blog section. We cannot discuss specific medical cases or provide direct medical advice in this webinar. We will have time for questions and answers at the end, and we will use the question and answer functionality of Zoom. So as we're going, feel free to load your questions down at the bottom, and then we'll capture them all at the end. Dr. Sharschmidt, Piero, and I will manage the questions, so you can just ignore that. If you're seeing questions pop in, we'll try to capture them all at the end. So thank you all so much, and we'll turn it over to Dr. Sharschmidt.
Awesome. Well, thank you. And let me just get my slideshow loaded up here. Can you guys see this slides okay there? Great. Well, thanks, Piero and Emily, for inviting me to give this talk today. And again, thank my partner, Dr. Setti here at Nationwide Children's for sort of connecting us as well. And really what I want to provide today is a little bit of an update of what we're doing on the surgical innovation side, you know, until your group or groups like yours actually find the cure, as Piero said, for this disease. Unfortunately, we're still forced with trying to find good local control options to have good outcomes and better functional outcomes. So that's a little bit what I'm going to focus on as part of my talk today. So thank you again for inviting me. And obviously, I'm preaching to the choir a little bit on this, but one of the struggles that we have in dealing with Ewing sarcoma or osteosarcoma or these primary bone tumors in kids is, you know, they're the rare disease. And when we look at them compared to other types of malignancies, it really pales in volume that we see, which makes it sometimes hard from a research innovation standpoint to get meaningful things done. So it's really super important for groups like this to continue to support these causes and help us to find better outcomes and hopefully potential cure for these rare malignancies. And we approach sarcoma as a team sport, right? It's us on the surgical side, but we also rely really heavily on our partners with our surgical oncologists, our medical oncologists, our plastic surgeons, our pathologists, radiologists, so on and so forth, that this is really a team sport. So, you know, we need to approach it like that and really optimize things to have the best patient outcomes we can. So just a little bit of background on my side of it. So on the orthopedic oncology, the local control side of it, you know, these limb salvage operations or bettering care for these patients didn't really used to be on the radar. I mean, a lot of these patients, unfortunately, would go on to early amputation as soon as we had diagnosis. And for Ewings in particular, we know that, you know, doing an amputation at presentation didn't help at all with long-term survival in curing the disease. So that's when sort of what we call the modern era of limb salvage sort of started to evolve, and that really happened due to a couple of things. Number one, our medical oncology team got better at the regimens that we give to help give curative outcomes for these patients. So the development of chemotherapy and those agents was important. Otherwise, limb salvage really wasn't needed, right? We got better at looking at these things. So the advent of MRI and contrast and PET scans and all the modern imaging that we use, it got us to look at these tumors in a way that we could salvage limbs that were previously thought to be unsalvageable. We got better at learning how to take them out, which obviously goes along with those first two key points. And the key point about the team sport, you know, we have these multidisciplinary oncology centers now where we collectively put our minds together to sort of come to the best outcomes. And then maybe most importantly is working not only with ourselves, but with our plastic surgery colleagues and our reconstructive surgeons is when we do, unfortunately, have these big surgeries, we learned how to put things together better to have a better functional outcome. So the development of all these things really allowed this sort of modern era of what we call limb salvage to come into existence. But obviously the preservation of limb function or limb salvage also creates some unique challenges, especially in the growing child. So all these treatment strategies or courses have to be individualized, with the goal being optimal limb function instead of always just being limb salvage, because there can be multiple circumstances where an amputative surgery or rotation-plasty or some of these other options we have may actually lead to better function. So we have to really individualize this treatment strategy. When we globally talk about limb salvage, there are multiple operations we have, or multiple things we can do to reconstruct limbs. And some of these we'll talk about today, particularly in what we're learning about allograft reconstructions and 3D printing and modeling, and what we'll call the virtual surgical plan. And I'll talk to you about the advances in that. We have the expandable implants we use almost as standard in growing patients these days with the Stanmore prosthesis, or now in Bioncos. It's really allowing us to continue to keep up with limb growth. And I won't talk a lot about that today, but happy to sort of answer questions offline or in a separate episode if appropriate. And then I will give a little bit of an update on some of the advances we're doing in the amputee patient space to try to better have functional outcomes in those patients, and what sort of the future looks like in amputee care. So those are sort of the overall limb salvage sort of scenarios we talk about. And what we've learned is that limb salvage is usually possible even in extreme cases. This case on the left is a pathologic fracture, which, often used to be an automatic amputation. Now we're able to salvage this patient through their preoperative chemotherapy and then put in a non-invasive expandable implant that you see on the middle slide there, and keep up with growth over time. Or the X-ray and MRI on the right of a Ewing sarcoma that's very close to the joint, that now, due to some of our virtual surgical planning and modeling, we're able to preserve joints and preserve limbs in cases that would previously be amputations. So again, limb salvage is usually possible even in some of these extreme cases. And we have some contraindications of sort of how we make that decision process, because it's not easy. And, obviously there's some decision aids out there as well that really help patients and family work through these things. But when we're looking at this from the clinician side, we have some sort of straightforward complications or contraindications of when we consider limb salvage. Probably the two most important being when you have extensive neurovascular involvement, or when the tumor is progressing through chemotherapy. Some of those really make us take pause to make sure we're doing the right operation. But outside of that, we know there's multiple other factors we have to consider. And if we're taking the best care of patients we can, we need to consider when we're trying to make this decision of how and when we should salvage limb, or what that optimal local control strategy is going to be. So we need to look at all these other factors rather than just the biology of the tumor to determine what's going to be best for patients and their families. So when we look at this, there's going to be functional differences between those, and that's not always saying that amputation is a worse functional outcome than a limb salvage, but there's going to be functional differences, and we have to have those discussions. There's going to be quality of life differences, and not only immediately after the operation, but long-term quality of life sort of situations that we need to consider. So in general, I think there's still sort of a dogma or a consensus to favor limb salvage, but we have to sort of recognize that this is associated with higher rates of complications and often reoperations and potentially secondary amputations in up to a quarter of patients that decide to go for that limb salvage route. So we have to have those conversations and openly and honestly and transparently trying to figure out what the best outcome is going to be for patients trying to make this decision. So, the functional advantage of limb salvage is not always consistent, and it doesn't always translate into superior quality of life. But we know is when we can maintain the best level of function, that's going to ultimately lead to the best quality of life, whether that's an amputation or limb salvage. And, this is a case of a patient of mine who had a osteosarcoma of his distal femur, underwent a limb salvage operation, had a great response, had 100% necrosis to therapy, recovered well, and then 3 years down the road developed this local recurrence around the tibia of the osteosarcoma, and at that point decided to have a rotation-plasty performed as opposed to more of a limb salvage operation. And again, we know that in these patients that getting to that best function overall is going to lead to the best long-term quality of life. So how do we sort of make those decisions? So with that as being just a really brief introduction as sort of some of the thought process behind how I think we should approach these patients, I want to transition a little bit now to some of the advances we're making for patients that do decide to undergo a limb salvage surgery. How can we make that surgery better? How can we optimize that surgery? And how can we make a very complex operation easier and safer and more predictable in outcome? And this is where I think that some of the 3D modeling and virtual surgical planning is really what I want to focus a large portion of this talk on. So, this is a slide I think that puts us in a really good context, at least in my mind. And I had one of my mentors when I was doing my spine training often would say, we never get on a plane without a pilot having a full flight plan in place, including sort of detours and things to work outside the box, having that completely in place before we take off from the ground. Yet in surgery, we tend to do that. We tend to get to the operating room, and although we have a general surgical plan in mind, we don't have a lot of the specifics or a lot of the nuances worked out until we get there. So I think that is really a way of doing disservice to the patient, and I think we can do better, frankly. So virtual surgical planning allows us to virtually review the patient's anatomy prior to getting to the operating room, similar to how a pilot would do on a flight simulator before actually taking off into the air. So this is our current sort of treatment method planning with myself there on the right-hand side and our radiologist on the left. And this oversimplifies it a little bit, but I think you'll get the point that, right now our radiologists, they take what they know from the CT scans, MRI scans, and really two-dimensional pictures and try to construe a 3D anatomy picture of what this looks like. So they'll do this and give us sort of a readout of how things look in two-dimension. And then on the surgical side, we try to take those images and reports and take those two-dimensional images, and in our mind, oftentimes try to create a three-dimensional picture of what this is going to look like to allow us to plan in advance and limit some of the on-the-fly decision-making, if you will. But this is sort of the current method of how we plan these very complex operations. And so our problem statement is really, we see things in 3D anatomy, but we often process things in the two-dimensional images we have at hand, which is a little bit of a discordance if we're trying to really optimize outcomes. So what would be ideal is to be able to touch and to feel and to comprehend the anatomy before getting to the operating room, because otherwise we're trying to do this mentally in our head and construe these pictures, which again is a very challenging thing to do. And what we do know is when we're finding out surgical solutions on the fly in the operating room, it leads to a lot of outcomes that we don't like, right? The surgeries can take longer. There's longer anesthetic time. Due to those things, there can be a higher risk of infections and really suboptimal surgical outcomes. So again, I think we can do better than we're currently doing with our current state of surgical planning. So our solution for this has really been to create patient-specific processes to preoperatively plan these surgeries before we get to the operating room. And this is Dr. JP, as we affectionately know her here at Nationwide, and she runs our 3D printing lab. And I think she may have given a talk to this group or to similar groups in the past. But we sit with JP before all of our cases and virtually plan what these resections look like. And we'll give you some examples of how this happens. So what are patient-specific uses? And these can be either single-use devices or 3D models that we can use, and I'll show you some example of those. But the overall goal of this is to take our virtual surgical plan and be able to transfer that to the operating room, which is going to lead to better outcomes for patients. And these can be osteotomies or corrective surgeries, or really the complex tumor resections, which is what I'll focus on. What we learned a lot about this really started with our ENT colleagues, believe it or not, where they would start to look at some of the mandible resections they had for different cancerous tumors and use vascularized fibulas to reconstruct these. So this is an example of a patient who had a cancer in the front part of their jaw, and using this virtual surgical plan, we're able to model the patient's own fibula and how that would be transferred up into reconstruct the mandible. And once you have that virtual surgical plan in place, on the bottom slide there, you'll see an intraoperative cutting jig can be designed that can basically then reproduce that anatomy real time in the operating room to reconstruct that. So we started to learn some of these concepts from our ENT colleagues and really transfer them to the orthopedic space. So this was one of the first patients that I used virtual surgical planning and a 3D model on. This was a Ewing sarcoma of the scapula. And just to walk you through the process a little bit of how this works is we take our data acquisition, we call it, where we get the CT and MRI scan. And the CT and MRI scan are actually merged together to create us a sort of a picture of what the tumor looks like with both of those modalities. And then from that image processing, we get a 3D model, which you see there on the screen, which is a 3D PDF model. But this is a 3D PDF that I'm able to rotate and manipulate and turn and remove certain sections of the bone on the computer screen before we get to the operating room. So once we have that 3D surgical plan and virtual modeling done, then we actually can print a 3D model that's a life-size exact replica of where the tumor is in the patient that will allow me to manipulate that model preoperatively and also design things like cutting guides, as you see here on the scapula and in the middle picture there, that can be then used in the operating room. So we're taking a virtual surgical plan that we're doing. We're performing the entire operation virtually before getting to the operating room. Once we have that plan in place, we transition that to actually print a 3D model and custom cutting jigs to make the tumor resection more predictable. So it's just a little bit of an example of some cases that we've used this technology on. This is another Ewings patient that we had that had a very large Ewings of the pelvis that, again, we can talk probably as another discussion about radiation or surgery, the combination therefore for pelvic Ewings. But this is a kid who had a tremendous response to his neoadjuvant chemotherapy, and the soft tissue mass has actually shrunk down completely. So this allows us to, again, virtually surgically plan. You can see the two pictures on the bottom, one being the virtual surgical plan where the red is his bony pelvis and the blue was from the MRI scan superimposing where the tumor is residual on his pelvis. And then on the right is the clear model that we actually print and have for use in the operating room, where we can plan our resection margins and really have this all in place before we get to the operating room. So again, a very precise way to allow us to do some pretty complex tumor resections in a way that we never have before with the preciseness. So the 3D model really allowed us to have this precise surgical plan, and it really allowed for a negative margin resection, which we know in these tumors is going to lead to a better survival overall. So allowing us to do this in a much more precise fashion. So the next iteration of this is obviously, if we're going to make these large resections, can we also use some of these same processes to have better implants to reconstruct things when we have to do a tumor resection? So we're now using this virtual surgical planning to also plan for our custom implant design. So this is an example of a patient we had that this was an osteosarcoma, but an osteosarcoma of the acetabulum, that after we did the tumor resection, we were able to design an implant in a 3D space to sort of recreate the patient's anatomy again, in a very precise fashion. So some of the power of this technology, this is a patient of mine that had a failed allograft. So she had a Ewings of her pelvis that was treated with an allograft reconstruction previously. And we know allografts tend to not last sometimes over time. And unfortunately, her allograft sort of melted away, and she had failure of the allograft where her femoral head and her hip replacement was starting to migrate actually into her pelvis and cause pain and difficulty with ambulation. So now using some of these processes, we can get CTs and MRIs of where the patient's anatomy is now, and we can design these custom cutting jigs to sort of do the resection we need to have happen, and then ultimately redesign the implant to recreate the pelvis anatomy as well. So sort of taking it now from not only on the cancer side of things, being able to remove the tumor in a more precise fashion, but now how can we take the next step of reconstructing in a more precise fashion, again, to have a better outcome overall. And so this allowed really execution of that plan that we had preoperatively to be done in the operating room. And this is an x-ray of how that implant looks. So again, allowing us to recreate the pelvis and recreate some of that anatomy that was difficult to do before we had some of this technology. So we're expanding this now and really using this as a standard of care on almost all of our tumor resections. So this is a very large pelvic chondrosarcoma that was a patient who came and saw us for actually over in Saudi Arabia. And you can see here with combining the CT scan and the MRI scan gives us this very precise segmentation and virtual surgical model of where the tumor is. So it allows us, again, before we get to the operating room, to plan where the pearls and pitfalls and and the challenges of this operation are going to be, and work through those in a three-dimensional fashion before we get to the operating room. So once we do our surgical plan, you can see in the bottom set of slides here is we're able to sort of recreate this resected specimen based on our model that we made through preoperatively. So it allows even these very large, very complex resections to be done in a much more precise fashion. So this is now a patient who had a Ewing sarcoma of the humerus, and for some of these in the humerus, we'll use what we call a biologic reconstruction. So using a vascularized fibula or some other bone transport for the resection and reconstruction. So on the left-hand side, you can see again the MRI scan and CT scan that we obtained preoperatively, and now the rotating image in the middle is that virtual surgical plan that we're able to make, defining the patient's anatomy and where the tumor is after treatment, so we can plan our surgical resection. And in this case, we plan to reconstruct this with a vascularized fibula. So not only can we model where the cancer is, but we can model where the fibula is and how that fibula can be transported, including the blood supply to the fibula, up to the humerus to allow a more precise reconstruction for these patients. So again, just showing it now without the rotating pictures, we can preoperatively plan the resection, plan our resection plan. We look at the fibula, can transport the fibula over the patient's anatomy to see how that's going to fit and how things are going to sort of be rebuilt from that standpoint, and then plan our resection and reconstruction before ever getting to the operating room. And again, once we have that virtual surgical plan in place, we're able to print models of exactly what this looks like. So we print models of the humerus, we print a resection guide for the humerus, we print models of the fibula, we make a resection guide for the fibula, and then we can also print a model of what this reconstruction is going to look like. So we can sort of have every step sort of performed in our mind's eye before getting to the operating room. So here's just a couple more case examples. This was a patient who had a very large tumor of the proximal humerus that we want to try to preserve the joint, because we know if we can preserve the rotator cuff and preserve their humeral head, that's going to lead to a better functional outcome. So being able to virtually surgically plan and create these very precise cutting jigs now, we're able to spare structures that before we had this technology, honestly, this probably would have been an entire metal reconstruction of the whole shoulder joint. So this allows us to really resect in a much more precise fashion, save vital structures that previously would have been, again, likely resected. So there's a couple of photos. Again, especially being over the lunchtime hour, I took out a lot of the surgical photos here, so that hopefully if people are eating during this, they won't be grossed out by some of the pictures here. But this is just some of the technology. So now when we get our allograft reconstruction based on our virtual surgical plan, we also create a cutting jig for the allograft. So what's shown on the left here is a cutting jig for the allograft that we obtained. And in the right-hand panel here is me on the right holding the allograft that we've cut based on our preoperative 3D printed plan of what that allograft piece should look like after we cut it. So you can see sort of the preciseness that this allows us to sort of perform in the operating room is we're doing things down to the millimeter now, where before I would challenge that we weren't able to be this close and this precise in some of our resections. And this is just the postoperative x-ray from that same patient showing the allograft that fits completely into the slot where the tumor was resected. And we fix it with some plate and screws to sort of hold everything into place. But again, being able to preserve the rotator cuff and the humeral head and lead to a much better functional outcome for this patient. I think this is the last example of some of our 3D technology, but again, now we're expanding this to be able to sort of plan where our hardware is going to be placed on some of these patients. So it's the next iteration is getting into the reconstruction effort. So this was a very, very large Ewing sarcoma of the humerus. You can see, hopefully appreciate on the MRI scan there, that this tumor really took up probably 80% of the humerus in this child. And you can see on the right there, our virtual surgical plan where the purple is the tumor and the red is looking at our resection specimen. So again, being able to plan very precisely before we get to the operating room how we can perform a limb salvage with sparing the joint on both ends here, which is very important from a functional outcome standpoint. So now, as again, the extension of this virtual surgical plan, now we're using some PDFs we obtained from the different companies that make implants, and we're able to plan our plate fixation on the model before we get to the operating room. Again, this traditionally has been sort of an on-the-fly sort of process where after we would do our resection, we would fit our allograft and we would sort of figure out what plates fit best to fixate that down to the bone. Whereas now we're able to plan all of that preoperatively. And this was actually a plate that was originally designed to use around the ankle joint, But in our modeling, we discovered that this would fit precisely where we needed it to, staying short of the growth plate, but being able to get fixation of our allograft into space. So we're able to superimpose the plate fixation onto our models to figure out what plates and which screws would fit in what location. So again, making things very precise and very predictable, where it used to be more of an on-the-fly decision. So this is that same patient now designing our surgical cutting guide. Again, this gets applied in the operating room, where again, you can see we're staying short of the growth plate on this patient, able to form a very close resection, both proximally and above the elbow joint, to allow us to salvage the joint, but still give us very meaningful and negative surgical margins for these patients. This is high-priced real estate, right? I mean, this is working between all the nerves and the vasculature of the upper extremity to preserve function for the hand. So being able to plan where all these structures are, again, I can't sort of highlight the importance of us from the surgeon side, having this comfort knowing we have all this planned out before we get to the operating room. This is demonstrating the cutting of the allograft now intraoperatively, showing sort of the preciseness of how we're able to perform that resection of the allograft, and then ultimately using the plates just as we designed preoperatively, fit perfectly in the operating room. So it takes a lot of the guessing game out of place once we're executing this plan in the operating room. So, the benefits, hopefully you're getting the sense, the benefits of what we think the 3D model visualization is it really gives us a better visualization of the spatial anatomy and the relationships before we get to the operating room. It allows us to try different options virtually before we get there. So we know what plates we're going to use. We know if we need a custom device and can print and make that custom device before the day of surgery. It allows us to identify risks ahead of time. Again, identify those pitfalls that we can encounter during an operation, to really have better preparation overall for complicated surgery. So I think this has been a huge advance and something that we're really excited about as far as what the future holds in terms of this technology. So the advantages of doing this is we get a better accuracy for our margin status, right? So we have less chance of local recurrence. We can precisely, as I've showed you, replicate that pre-surgical plan. So it allows for a shorter procedure and a safer procedure in the operating room. So that's going to lead to lesser infections and cost savings because of that as well, because we're operating in a much more efficient manner. But overall, and the bottom points here is that these are safer procedures. This makes for better outcomes, better functional outcomes, better oncologic outcomes if we can precisely replicate these operative plans before we get to the operating room. So with that, I'm going to switch gears for the last part of my talk here before we open up for questions. Is just, although we spent a lot of time here showing how we can salvage limbs better, that's obviously not always the right answer for some patients. And we often think it's often additive by subtraction, right? That functions can actually be better with an amputation procedure sometimes. So we also need to do advanced care for those patients and make things better when the amputation is the correct surgical outcome or the correct surgical option for these patients. So amputation is not necessarily bad. And oftentimes it can lead to better outcomes despite some of the advances we're having. So a little bit of background on amputations, just to highlight some of the challenges that we have, is that we have two main issues with amputations, is that function has not always been the best. And this is obviously a historical picture here. We've come a long way from some of these old arm prostheses that were the original sort of hooks that were provided as the outcome for patients. But function wasn't always the best for amputation patients, and pain. And that pain can be from a couple of different things, whether it's from what we call phantom limb pain, or the sensation the limb's still there and it's painful, or the formation of neuromas that can occur in these patients. But function and pain has not been great traditionally in amputation. So how can we do better for our patients in this regard? And these are big problems for patients that have to undergo amputations. We know residual limb pain can happen in 3/4 of patients. Phantom limb pain can happen in more than that. So a lot of patients who undergo amputations can have residual pain, unfortunately. And there's a lot of amputations being performed in the United States, not just for oncologic regions, but for traumatic regions and congenital regions. But there's 185, almost 200,000 amputations performed a year in the United States. So this is a huge patient population that a majority of patients traditionally are going to have some issues with function and pain. So again, we saw this as an opportunity of how can we sort of better care for these patients. So the challenges are this residual limb pain is a common complaint, and it's usually a secondary to either the neuromas, the phantom limb pain. And we also know that some of this neuropathic or residual limb pain is potentiated by chemotherapy. So you take a really young patient, you give them drugs that make their nerves more sensitive, and then they have to get an amputation. And this patient population in general is sort of set up to have long-term problems because of these issues with amputations. So our team here, again, we think with our amputee patients, this is also a team sport. We have a lot of people who are involved with this process, and myself on the orthopedic side with my partners, and we work with our plastic surgeons here. I'll explain why our plastic surgeons work with us on every amputee case that we have, but then also the rehab after that. So we have Dr. Napolitano is our rehab specialist, that he has an adaptive patient clinic that we're there in clinic with him and with our prosthetists and sort of real time trying to treat this as a team sport to optimize outcomes for our patients. So and really what I'm going to finish my talk with here is one of the advances that we're having with the amputee, and a lot of people on the call have probably heard of this technology before, but it's called targeted muscle reinnervation, or TMR. And the idea behind TMR is it's been developed to help us help with phantom limb and residual limb pain, but then ultimately, and really what I want to focus on is open the door for what we call a bioamplifier or a bioprosthetic down the road. But what the idea behind TMR, let me get to my next slide here to show you, is the idea behind targeted muscle reinnervation is if you have a patient who unfortunately has to have an amputation, those nerves obviously get severed as part of the amputation. And traditionally, they would either get sort of buried in the tissue around there or managed locally. But that would lead to neuroma and phantom limb pain by leaving that sort of live wire in there as part of the amputation process. So the idea behind targeted muscle reinnervation now is instead of leaving those nerves, what we call live wires in there, we'll identify a muscle somewhere around the amputee site. In this example, it's the pec muscle. And we know that pec muscle has its own individual innervation. And the idea behind TMR is now taking those severed nerves from the amputation and rehooking those into those motor units of a surrounding muscle. So what this does is a couple of things. It gives the nerves a job to do. So what we found is this greatly decreases phantom limb pain, narcotic use, gabapentin use in our patients, but it also leaves the door open for what we call a bioprosthetic, and I'll explain what that means. But we're doing this TMR, rerouting these severed nerves, as standard of care now in all of our patients, pediatric and adult, who have to have any sort of amputation procedure. So the idea now is what the bioamplifier is after we get through the acute postoperative period, and again, we know it helps with that immediate postoperative pain and nerve pain and neuroma formation, but because those nerves now are rehooked into the pec muscle, the patient via Bluetooth sensors can now learn to fire the pec muscle to power the arm prosthetic. And we'll show some examples of that. But what this allows is for the patient here is actually in their mind thinking that they're opening and closing their hand. And you can see how that's now firing muscles on the chest wall because those nerves have been rerouted to that space. And we can now use this technology to now interact with the prosthetic and give more functional and better functional outcomes for these patients. So this is one of our adult patients over at the adult hospital, but this is a patient who had an upper extremity shoulder disarticulation, and he had targeted muscle reinnervation done to his chest wall, and he's powering his hand prosthetic now by firing the muscles on his chest wall and via Bluetooth technology being able to power and use the prosthetic because of that. So with some of our arm amputation patients, we're down to individual finger control and picking things up by doing this. And obviously the next iteration of this is we're exploring this technology with our below knee amputations, our above knee amputations, hopefully combining this with some of the other things you've heard like osteointegration over time to really, again, lead to better functional outcomes for this very challenging population. So with that, I'm going to end my portion of the talk. That was covering a lot of topics in a short period of time, but happy to stick around and answer any questions. But again, I applaud this group. Emily, Piero, thanks for inviting me, and super sort of excited, and it's awesome the work your team is doing. So looking forward to working with you guys more, but happy to answer any questions that may have come up.
Wow, that was incredible. I feel like you should have a Netflix show. I would binge it. You do a beautiful job explaining what you're doing, and what you're doing is really incredible. It means so much to this population that these advances are here, not something coming down the road, but are here. So thank you so much for doing such a beautiful job explaining your work. So I think a lot of people are going to want to know, why isn't this being done at my local hospital? Or how do I take advantage of this if I'm not, in Ohio and have access to you?
Yeah, well, number one, obviously, happy to be a resource for questions or anything for any patients or families if they're trying to make some of these decisions or at least talk through the technology. And I think we're really pushing some of the innovation here, but I would say that a lot of centers now, because of some of the work not only here but at Walter Reed and some other hospitals, are doing TMR. So I would definitely ask that question if your child is considering an amputation. You should definitely ask whether the center offers TMR, because likely if they're not, there's going to be somewhere close that is. So that's on the amputee side. And on the virtual surgical planning side, we're trying to get the word out about this, and a lot of we're working a lot with industry and the companies to sort of have this offering as well. So I think it's one of those things. These are questions I ask preoperatively, right? What about this technology, or am I a candidate for this? And likely if you're at a center that's not doing it, there'll be a center somewhere close that will be. So.
It's fascinating. I just have a general question. I want to back up a little bit, and something that kind of just occurred to me while you were speaking. And this is the second time I've seen these slides, and I'm still dumbfounded and just taking it all in. But super grateful that someone like you is out there doing this for these kids. Is the time span, like how long is this horizon that you talked about, like the VSP to the 3D model to the custom implant? Was that building blocks off of each other? And like what this is 5 years, 10 years? How long of a horizon did this take to get to this point?
Yeah, so we've been doing the 3D modeling piece for probably about the last 7 or 8 years, and we get a 3D model on a virtual surgical plan and 3D model on every one of our patients who's having a limb salvage surgery, just to try to learn more about the process and the value of it. And we use it from one piece we didn't talk about is an education space, not only for us and our trainees, but for families. It's very powerful, and not all families want to see it, admittingly, but it's very powerful if they're interested in it, that I can show you, preoperatively, here's where the cancer is. Here's our challenges of surgery. Here's what we're planning. And I think it does a couple of things. Obviously, it allows everybody to be on the same page and understand, what we need to accomplish. But I think there's also some comfort into knowing that we're working this hard before getting to the operating room to make this surgery as predictable and safe as possible. So I'm getting a little long-winded in my question here. I apologize, but we've been doing 3D modeling for about 5 to 8 years. The plates and the custom implants are probably over the last 2 to 3 years where we're using that more routinely. So it's been probably about an 8-year process in total.
Okay. And if I can dovetail off that question, do you view this as a precision medicine? Like, do orthopedics talk about this as precision medicine? Because we talk about that in terms of like a druggable target in an individual patient, but this truly is precision medicine. I'm just curious to know.
Yeah, it's until you guys find the cure for Ewing, so we don't have to do these operations, we want to make the outcomes as predictable as possible. So this is definitely precision medicine for the local control piece of what we currently have as far as treatment goes, for sure.
Cool. Okay.
Yeah. What's the time frame needed to plan and prepare for one of these surgeries?
Yeah, that's another really interesting question, because it's something we're working through now. We here are big believers into having this process being local at the hospital, right? That, JP's lab, I showed you JP's picture, her lab is literally the floor down from me. So it's something where we can go down between clinic patients, between surgeries, whatever that may be, and plan things real time, in person. Although admittingly, there's a lot of industry partners that are also sort of perfecting this technology, and we've gotten really good about doing things virtually over the last couple of years. So we do a lot of Zoom calls and Teams meetings, working with industry sometimes. So the virtual surgical plan, when we're doing it locally here, takes a week or two to do. If we're going to print the models, there's some technical aspects there of how big of a model is and how long it takes to print, but typically the model will take about a day to print. If we are going to do a custom implant, that's a whole sort of different question, because that goes through the FDA compassionate use pathway, and we have to get that approved, and then industry makes those custom implants, and that typically is around a 6-week process if we need to make some of those like hemipelvis implants that I showed you or something like that. So to do the virtual surgical planning and resection plan takes a week or two, and then the implant has a whole other degree of sort of time on top of that.
Mm-hmm. So for the patients that come in with a pathologic fracture, what kind of components of this space do they benefit from?
Yeah, I mean, I think
they may need to be fixed up a little faster than you have.
yeah. So I think these will benefit from the same sort of technology, right? And maybe even more so, because we know, especially in the pathologic fracture population, we have to take in consideration what contamination was done from the fracture itself. And now from the MRI scan, we can model that into our model and sort of take that into account. Now, most of those patients are not going to be custom devices. So, most of those patients, if we had a patient that came in with a pathologic fracture that we needed to get them the virtual surgical plan and modeling done, we could do that within a day or two easily if we needed to sort of push the process. So I think that patient population benefits likewise as if they weren't fractured.
Right.
Okay, another question about growing bones. We're talking about local control in kids, obviously, that have growing extremities. And I know you kind of alluded to this in your intro, and you do some work in non-invasive expandable endoprostheses, and perhaps that's a talk for another time, but can you comment at all on that briefly?
Yeah, so how it relates to this 3D planning of those of the cases I showed you is if we're able to save joints now that maybe we couldn't save before, and save growth plates and do a biologic reconstruction, I think that's where some of the power of this technology is, being able to avoid the expandable implants. That being said, obviously, a lot of these come all the way down to the joint surface or require the growth plate to be resected, regardless of our virtual surgical planning. So in those patients, we're really working to improve the expandable prosthesis sort of space with Oncos, primarily as they're now owning the Stamor prosthesis, trying to sort of perfect that technology and sort of do a redesign on that as well. So the expandable prosthesis is, or the JTS, the non-expandable or non-invasive expandable prosthesis, is something that is a great option for these kids. Obviously, it helps us to keep up with limb growth and to do things in the office with our lengthenings and things. But there's some challenges with it as far as limited availability to get MRI scans and having to resect the joint or replace it. And there's still a lot of room for improvement with that device. But having the non-invasive option is a huge advance for that patient population for sure.
Thanks.
Excellent. We had a question from Hillary about the nerve replacement positioning. Is this something that can be done after an initial amputation, or does it need to be done at the upfront in the primary amputation?
Sure. No, we find that the results are best if we do it as part of the primary amputation, but we've done a handful of secondary TMRs in patients who have already had, not a handful, a fair number of secondary TMRs in patients who had prior amputation and really struggle with either phantom limb pain or neuroma pain. And we find that the results are still good. They're still better than if you don't do it. They're not quite as good as if you did it primarily. So we still recommend it for patients if they have issues with phantom limb pain or nerve pain or residual limb pain. It's definitely still something to consider for sure.
Awesome. All right, we have a question here from Janet. Janet, thanks for being here. She says one of the complaints she often hears on the patient-facing side is that the implant that they received for their LSS was the wrong size or too big for their child. Do you plan to partner with other institutions if they don't have the technology available to them right now?
Yeah, so I mean, again, happy to collaborate or plan or be a resource for anybody and everybody who we can help for sure. But that's absolutely, Jen. I mean, that's one of the challenges with doing these surgeries in really young people is that they're really small, right? So if you're using a lot of the standard implants, sometimes they can be too big or not the right implant for that child. So we do a lot of work with not only the allograft and the vascularized fibula or the biologic reconstructions that we talked about, but we do a lot of work with our industry partners as well with custom devices or compassionate use devices to make sure we're getting the best implant possible for the very young patient.
Excellent.
Thanks.
I know you mentioned that these virtual plans reduce the amount of time the patient is open in the OR. Christina asks if you have any data to support that, suggesting that a decrease in OR time may be a great selling point to hospitals who have yet to get on board with this.
Absolutely. So we published our first series, just sort of outlining the process of doing the data acquisition, the segmentation, and getting the plan together, and just sort of listing the benefits as we saw them, and the OR time was included in that. But it's something we continue to follow. For most academic places, OR time is super expensive, I think, to the point you're getting at. And some places it's like $100 a minute to have a patient asleep in the operating room. So even if we can save 15 minutes on an operation, that can translate into huge cost savings for the hospital system. So that's one of the ways that we've talked to our hospital administration about getting support for these initiatives is, yes, it makes sense. It's cool technology. It's pretty pictures. It's all those things. But if it translates into better patient care, and from the hospital administration side, a more cost-effective operation, that really helps move the needle to get this technology more widely accepted for sure. So
thanks for that. I got another general question that just popped in my head. Can you talk about like the 3D custom models that you create? I would imagine as a surgeon, like being a very hands-on practice, can you speak to like the benefit of actually having something tangible in your hands prior to going into surgery? What a benefit that is. I can only imagine.
Yeah, I mean, I'm sure everybody on the call has worked with orthopedic surgeons before, so we sort of have this picture of where just have these big mallets and hit things harder if it doesn't work, that sort of mentality. But it really allows us to be much more precise in our plan. And this is it. I have a model here on my desk actually for a patient we did very recently. That this is a patient who had a large osteosarcoma of their pelvis, and this is an exact replica, size-wise, match-wise, detail-wise of the patient's anatomy. So, me being able to hold this before getting into the operating room and being able to say, oh gosh, I know when we identify this bony landmark in the operating room, that's where we want to start our resection, or we know the vessels are coming right here, so this is going to be an area we have to be very diligent and careful in the operating room. But being able to have this and being able to your point, hold it and move it and manipulate it has made things so much more predictable and just put all of us at much more ease going into these big operations than we've ever had before. So I think, I can't sort of overemphasize, how much we use these. And, we've experimented with surgical navigation, and we still use navigation sometimes, but we really found that these models are almost more powerful than intraoperative navigation in giving us a preciseness for our resection plan. So it's a huge advance.
Great. Hillary had a couple questions about the medium used as the implant. Are you 3D printing things that are eventually implanted, or is this to create the model for the allograft?
Yeah, so we hope to get to the point where we're able to 3D print. You can 3D print titanium relatively easily, but there's a huge expense to getting those printers and getting it, FDA cleared and everything that goes along with actually printing something and implanting it in a patient. But that's our goal, is to be able to print the implants in-house that we'll eventually use in the operation. Right now, those implants get printed by industry. So they're made by the individual implant companies that go through the FDA clearance and testing process, and then they're shipped to us sterilely for use. So what we're printing locally is the 3D modeling piece of it.
And then what are the ones that the industry are making? What are they made out
of? Usually either titanium. If the 3D printed, it's usually a titanium based implant.
And does it eliminate, does it reduce the number of, Hillary asks again, does it reduce the number of screws put in when you're working with a 3D implant, or has that changed at all?
So I don't know if it has reduced the number of screws, but what it allowed us to do is to plan where the screws are going much more accurately. So again, before, when we would use these implants, or if you're getting a standard hip replacement, let's say, you get your acetabular component in place and you sort of just drill and get the screw to fit where you think it feels good, per se. Whereas now we can plan exactly where the screws are going, what the size of those screws are going to be, if they're going to be locking or non-locking, and just be better at planning where the screws are going, which leads to a lot better outcome as far as the outcome of where those screws are going. So I don't know if it reduces the screws, but it makes the screws we use better for sure.
All right, got another question here. It says, has virtual planning 3D printing changed the way you are able to discuss the procedure with the patient family? And I guess on the patient family side, have you received feedback to with regards to like having a better idea of what is about to happen to his or her body?
Yeah, 100%. I mean, whether it's even the 3D, the PDF files of the model, sometimes that's enough to be able to talk through the process with the patient. But we offer to share those plans with all patients as they're coming through, whether it be the PDF model or the actual 3D model of it. In fact, we had one kid who had a big femur resection, and he wanted part of the model for himself. So JP printed him like a keychain replica of his femur before his tumor was resected,
Oh, wow.
which is a little bit bizarre, but maybe there's a market for that. I don't know, but no. So I think there's a huge value, and just like there is for us in seeing what we're doing before the operation. Um, we really struggle, I think, to set patient expectations as far as surgical outcomes before we get to the operating room. I mean, we can talk about it and say, yes, you need to have a distal femur resection and a total knee reconstruction. But now being able to tangibly show on a model what that looks like and what the challenges are and what the reconstruction is going to look like, I think helps that discussion in ways we thought greater than possible, honestly. So it really helps from that discussion standpoint.
All right, another question just popped in from Todd. He says, a few of the pictures you had in your slideshow didn't look to be titanium. Were they cadaver bones or a plastic type implant?
Yeah, so some of the pictures in the presentation were the cadaver bones that we use. So as part of this, and I didn't get too much into that, but if you're going to have an allograft or a cadaver bone reconstruction, again, it sounds sort of weird, but you sort of order the cadaver bones from the biobanks that have them. What this 3D modeling has also allowed us to do is be much more precise in the size and the fit of the allograft than we were in the past. So now when we order those allografts, we can size match them much better than we could previously. But then we also have those cutting jigs that we designed for the allograft so that the allograft will very precisely fit into the defect we created with the tumor resection. So yeah, some of those pictures were of the allograft being prepared to be implanted.
All right. Thank you for that. I think that's all the questions we have right now. We do have a couple minutes. Is there a way that patients can reach out to you or an MP or a PA if they have case specific questions to ask on a follow-up?
Yeah, for sure. I'm happy to share my email, and maybe I don't know, Pierre or Emily, you guys can share my email with the group, whatever is the best form for that, or
Okay.
on the website, wherever appropriate. I'm happy to share my email there and reach out to me anytime. I'm happy to talk through cases informally or formally or whatever that may look like. So absolutely.
Okay, we will do that. We'll post to your email for sure. Emma, are there any other questions that popped in last minute, or are we all good?
No, I was just gonna say, are you involved at all with the news tumor board that is run out of Cleveland Clinic by Dr. Trucco?
I don't think that I am. No, they're
Okay,
right up the
that
road from us, but no, I don't think so.
yeah, he runs a national tumor board specifically for Ewing's sarcoma, and I know they have cross-functional experts from across all the fields, and I feel like you would be an awesome add to that group to get that perspective in there. So Piero
Definitely.
was the Ewing matchmaker, so maybe he can.
No, you are now. Look at that. That's a great idea.
Awesome.
Yeah, I'd love to participate. And now you say that, I think Dr. Seti here is involved with that. I've
Okay,
hopped on that call a few times, but yeah, Pierre, if you could send that connection again, I'd love to be more involved with that.
Definitely will do. And on that note, I think we're gonna have you for a part two because it seems like there's no shortage of topics to discuss with you. That's cutting edge. So I just want to thank you for your time, Dr. Sharschmidt, and for pushing the envelope for these kids. It's truly remarkable what you guys have going on at Nationwide. And we're happy to have you and be a platform for increasing awareness on this topic. So thanks for being here. Thanks to my fabulous co-host and co-founder Emily for helping me out moderate conversation today. And thanks to the viewers for being here. We will have future Ewings episodes. We don't have one currently scheduled, but the easiest way to figure out what that topic is go to littlewarrior.org and navigate to the Ewings U tab on our website and subscribe to the news list there. Also follow us on Instagram and Facebook, as we always post about our next speaker that way. And then in closing, Dr. Scharschmidt, I don't know if you know this, but we always sign off with a simple 1, 2, 3, swords up. It's the way that that embodies our fight in honor and memory of so many little and big warriors who face this cancer. So I'm just gonna ask you on a 1, 2, 3, we're gonna do swords up. So 1, 2, 3.
Swords up.
Swords up, everybody.
Swords up.
Thanks for being here.
Thank
See
you,
you next
guys.
time. Thank you.
Thanks, everyone. Have a great day.